Good morning. This is Doug Rogers with the Counterweight, and happy Monday. I imagine we're off to a fantastic week. And this week, there's really only one thing that I am thinking about in digital health, and that is, what does it mean to be human and increasingly an AI world? We're not gonna get into some deep philosophical concepts or approaches here, but this has been something. I know it's not just top of mind for me. I think it's top of mind for a number of people. And what what are the ramifications of increasingly proliferation of artificial intelligent agents, if you will, that increasingly may work autonomously? What does that mean? What does that mean for you and I? What role do we play? What agency do we lose because of this? What's the good? What's the challenging? Uh, and I don't have all the answers. I don't, but there have been several things that I've been reading and thinking about over the last several weeks that just really brings that top of mind. And so one of the articles that really kind of crystallized this thought, or more so the desire to think more deeply about it, was a recent research article out of Google Research. The article is called Towards Conversational AI for Disease Management. And this publication was issued earlier this year. I think it was in February of this year. As I said, it comes out of Google Research, Google DeepMind, and it's a group of researchers in the UK who have created a model. And in essence, the research or the experiment that they ran is that they took an AI agent. Actually, in this case, it's two agents. It's a multi-agent model that they've created. They refer to it as AMI, the Articulate Medical Intelligence Explorer, AMI. But they created AMI, two agents. One is a conversational agent. One is a management reasoning agent. They just have different functions and they interact with one another. But anyway, these agents were then ran in a trial against primary care physicians. And the construct of the experiment is that they had a blinded study with real people. These were paid actors that were acting as if they were patients. And over a series of days, whether it was the primary care person or the agent, the patients would have interactions, and the interactions would be sequenced around trying to understand what their condition status was, and then making recommendations around a plan of care, following up on that plan of care, getting more information, and then ultimately giving guidance around either medications, treatment options, etc. And once again, the crux of this is that it wasn't just a single interaction or a single sequence of interactions one time. This was intentionally meant to be constructed where there were continual engagements over a period of days, and really you could think of, at least the way they frame it in this research paper, they frame the engagements as three distinct engagements over a sequence of days, really to mirror, if you will, the life cycle of what a real experience would be for a primary care physician engaging someone, diagnosing them, following up with them, treating them from some type of chronic condition, etc., that would happen over a period of time. And the results, candidly, were remarkable. What they found is, and I'll put the graphic up, what they found is that the AI agents, this multi-agent model, performed better in every category than the primary care physician. Notably, it was preferred by the patients and by specialists, meaning that the agents would reach out to specialists as part of a referral, and the patient and or the specialist preferred the interaction, got more value from the interaction with this agent, AMI. Once again, AMI stands for Articulate Medical Intelligence Explorer. They valued the engagement with AMI more than they valued the engagement with the primary care physician. As a reminder, the way they framed this study, the patient experience was blinded, meaning the people playing the patients did not know if they were interacting with a real person or Amy, this multi-agent model that Google had developed as part of this experiment. And here are the categories over these three visits, if you will, that they were scoring the performance. Management plan, is it appropriate? So really, was the care plan appropriate and right based on the diagnosis or conditions presented by the patient? Prioritizing patient preferences, monitoring and adjusting the plan, medication prescribing. Interestingly enough, this is the closest where human and agent performed in parity, whereas every other sequence, the agents performed either slightly or significantly better than the person. Clinical guideline selection, and then treatment precision. So once again, engaging a person over a set of sequences, in this case, multi-days, meant to represent how you would diagnose, initially define and propose a plan of care, and then engage throughout that plan, modify as appropriate the model that they explored, that they studied, and then that they measured. The multi-agent, Amy in this case, performed better in every single category than the actual primary care physician. And once again, I'll just simply restate this. The patients did not know who they were interacting with. It was a blinded study. So there was no bias per se. I'm interacting with an AI agent versus I'm interacting with a primary care physician. And look, there's a lot of detail. I'm going to drop the link to this research study. I encourage everyone to go out and read it. There's tremendous depth to what they talk about, and they provide a ton of content in terms of the prompts, how they built the agents, some of the challenges that they faced, what they would recommend as next steps, et cetera, et cetera. But really, the question is, what does it mean to be human in this environment? What if in today's world, now I'm not talking 6 months from now, a year from now, and advancements that will come, because I think we all recognize that the advancements in the artificial intelligence space is occurring at a breakneck pace. But if the current state can engage and perform better in a blinded scenario than primary care physicians across all of these factors, what's the benefit of the human experience? Why should we err on the side of having a human to human engagement in this? And I don't know the answer to that. Now, I'm gonna venture a couple of suggestions. These aren't deep by any means, but I do believe that there is an intangible loss in connectivity that increasingly becomes apparent over time when a person interacts with a non-person entity, in this case, an AI agent, versus interacting with a person. And we can make the argument, hey, we have robotized, if you will, people's interactions, especially in healthcare. They have a script they have to follow. They have to do all these things, and it's very structured, and you can't deviate from this because we want to make sure we propose exactly the right things, and we CYA from a regulatory perspective. But the reality is human interactions are unpredictable. They are messy. They are chaotic. And there is an innate understanding, I believe, between two people that picks up on that randomness, that chaos, if you will, that just lies below the surface of a human to human interaction that is not there when we engage with an AI agent. I also think about the unpredictable elements of kindness, or connectivity, that drives people, even when it is not the most obvious, to try to do something unique for another person. And when are those magic moments missed if a majority of these interactions are migrated to more of an AI agent? Now, I'm going to pause here because I think, what I'm talking about this morning, what I'm thinking about this week is, what does it mean to be human? And let me be clear, I'm extremely bullish on both the need and the role that AI agents should play in healthcare. I think they are an extension, an augmentation, an amplification, if you will, of our resources that could create an environment of abundance and helping and improving the health and care of individuals around us, of communities, of groups of people. And if anything, I think we should lean faster into thinking about how to integrate these agents appropriately into the care delivery process in a variety of different ways. And certainly that's happening today. But that doesn't mean, in fact, I actually think that it is of paramount importance that we have in parallel the conversation around the value and articulate the value of what does it mean to be human, and where should we look for and strive for the most human of all interactions. Now, there was another article that came out that was based also on a research publication. In this case, this was a publication that was done in the New England Journal of Medicine AI journal. So this is actually a relatively new journal. In one of my prior top 3 things, I referenced that I highly recommend they have a podcast. The New England Journal of Medicine AI has a podcast where they talk about the role of artificial intelligence, and they invite and typically are speaking to researchers, to clinicians that are doing very in-depth analysis of the impact, both good and challenging, of these models. The 2 hosts themselves are PhDs by background. Incredibly insightful podcast. But this particular article, which is entitled "What If AI Ran an ER Triage and What Were the Results?" So this particular article looked at over about a 3-year period, 2020 to 2023, the ability for an AI triage system, when given a set of information around the patient, who they are, their background, symptoms that they're presenting with, the ability for it to effectively triage, or in this case, segment patients presenting into the emergency room into the best category. And they really just had 3 categories: low acuity, medium acuity, and high acuity. And what the journal found, what this article found, is that the AI triage system, right, this was doing no human interaction. This was nurses inputting the information, and then the AI in its neural network structure was then giving a set of recommendations, or going through a tree list, if you will, to make a recommendation of where the person fit on acuity. What they found is that they moved more people. Now, this is roughly about nearly 200,000 ED admissions that this was applied to. They moved more people into a low acuity engagement than previous, and they had fewer people that were identified as high acuity. So said another way, that compared to what was happening in the human to human experience, the AI system was suggesting that people that typically would have been placed in either medium or high acuity really should have been more in a low acuity engagement, and that individuals that were in the high acuity, there were less of those that needed to be in that segment. So the output is that they saw a different stratification of acuity segmentation, and that they saw an increase in efficiency, meaning that people spent less time in the ED, to the tune that they shaved off, I think the number was somewhere around 80 something hours or so in reduction of time to discharge. So certainly a positive, certainly a positive, and a great example of where there's applicability for these AI components in healthcare. But then that story is partnered with an article that came out yesterday in the Associated Press that is titled "AI Nursing: Staffing Solution for Hospitals Are a Threat to Quality of Care." And in this particular article, it really goes through, and it's more so a discussion with key nursing leaders, both the representation for the National Union for Nurses, a couple of individual nurses, but it's positing, or it's talking about what is the harm, if you will, by removing the human nurse more so out of the equation. Now, the article picks on Hippocratic AI. Hippocratic came out early with this messaging: replace your human nurses at $40 an hour with this AI agent nurse at $9 an hour. I just, I've said this to many people. I think that was a wrong message. I think it actually sets back the conversation, and it was a mistake by Hippocratic to posit in that way. It does more harm than good, if you will, in terms of actually advancing the conversation of the right role that these AI agents can play. But in general, the article explores a lot of feedback from nursing leaders, nurses in general, about what do they see as the harm in removing the human from that example. One example that they gave, and this is an imperfect example, but they interviewed a nurse working at a hospital. It's a Dignity Hospital in Nevada. And this person described, this was not necessarily in reaction to an AI agent. This was a predictive model, which is slightly different, but that at their facility, they were running a predictive model to identify people who were at risk of sepsis. A particular patient was flagged. And because of being flagged, and they were flagged as having a high risk, that the recommendation was to administer a large dose of IV fluids. But upon further examination by the nurse identified that this person was actually being treated a dialysis patient with someone with kidney failure, and doing this large volume of IVs would be counter effective to actually putting the person in the best state of health. Now, that is a random example, and using that to paint a broad brush of whether or not these AI functions, these AI agents, are right or not, is not what you should do. But I encourage you, go read this article, but I think it's a good representation of the tone, the fear, the concern that people who are sitting on the front line of caring for patients have about removing the humanity from the process. So there's been a lot of talk in this industry. Once again, these conversations are moving so fast, but the new phrase that every company is now using is human in the loop, HITL. That's the acronym for this, human in the loop. And really, that's being thrown around as a placeholder for, hey, we are going to safeguard these AI agents. I think there's a lot of value to that construct, but there's not a little definition around what that actually means. So what is it that we're grappling with for this week? Well, what I would challenge our audience is continue to think deeply about what it means to be human. What is the connection, the unpredictable connection that you may have with another person that cannot be mimicked by an AI agent? And let's think and let's talk through what is the right way to balance the need for the human to human connection with the absolute need that we have in our industry to augment and extend our resources, which are dismally poor in terms of staffing today, with these AI agents that are, quite candidly, just absolutely incredibly smart and sophisticated pieces of technology. And there are right roles and there are imperfect roles for these tools. And once again, I'm extremely bullish. I think layering on these AI agents can provide a radical redesign in variety of venues of care, primary care, specialty care, inpatient interactions. It can create a mechanism to create more connectivity with people, to get more information, to create more awareness, to move us from a reactive engagement to being much more proactive in the conversations we're having with people about their health, their care, and how they can improve both of those entities. But let's not lose the human element. Let's keep that spark of kindness, that unpredictable moment of connectivity, and let's continue to make health and care a human endeavor. I don't know how we chart the course forward. This is just simply what I'm thinking about this week. I would love to hear your feedback. Drop some articles, give me some feedback, some commentary on how you would approach this. But nonetheless, the train of technology is not stopping. It's only accelerating. These are the conversations to have to make sure that we're embracing it in the right way that delivers the best outcomes versus the worst case scenarios. Happy Monday. I hope you have a great week. I'm super excited about our full length episode that's coming at the end of this week. We're interviewing Andy Relihan. He is the Chief Commercial Officer for a digital health company called Payground. More to come on that. It's going to be a fantastic episode. Stay tuned. Friday, 10 a.m., we drop that particular episode. Thank you for your time. See you out there. Have a great day.